Chapter 20, Heart Failure and Circulatory Shock. Lots of information in this chapter, but basically we want to focus on the heart failure piece and a couple of the types of shock. There are two types of heart failure: high output versus low output failure. So, heart failure related to cardiac output, heart failure related to systolic or diastolic failure, meaning the pump can't pump out enough. And we usually talk about heart failure in terms of being right-sided or left-sided. This is a high-level picture of what heart failure looks like and how heart failure stimulates different organs in the body. This is a great picture of the differences of right heart failure versus left heart failure. So understand that in right-sided heart failure, you get congestion of peripheral tissues. Your abdomen and liver become congested and impaired, your GI tract. And so the signs and symptoms begin to match where the tissue, where the blood gets backed up in the tissues. In left-sided heart failure, we basically have pulmonary congestion, which impairs gas exchange, may result in pulmonary edema where it backs up all the way into the lung tissues. Basically, you're going to see with left heart failure and activity intolerance because of the decreased tissue perfusion that gets significantly worse as the fluids continue to back up, and eventually you get the pulmonary congestion and the impaired gas exchange. Another high level and overly simplified, but may be helpful. The increased workload of the heart failure results in an enlarged left ventricle. Because of this, blood is pooling in that ventricle and atrium and backs up into the lungs rather than being distributed to the body. The beginning signs and symptoms that you see here are difficulty breathing or dyspnea, dizziness because the blood's not getting to the brain for oxygenation. You may see orthostatic hypotension. You're going to see decreases in the peripheral pulses, cyanosis, and potentially an S3 gallop. If this situation is not corrected, pulmonary edema will result from the increased capillary pressure that forces the water into the interstitial spaces. Signs and symptoms that you'll see here are coughing, crackles in the lungs, tachypnea, orthopnea, which is difficulty breathing upon laying down. And what all this means basically is that the right ventricle has now become stressed through an increase in pulmonary vascular resistance, and it causes a worsening of all the symptoms. We generally associate left-sided heart failure with end-stage congestive heart failure, but it can begin in the left side. Right-sided heart failure has an effect on systemic circulation. The right ventricle enlarges, the tissue is stretched, creating a deviation of the heart from normal placement. This in turn causes conduction issues. So the signs and symptoms that you'll see when this is happening is beginning arrhythmias because of the irritability of the conduction system being out of place. You'll see decreased cardiac output, palpitations, dyspnea, tachycardia, and a generalized cool skin cyanosis. The blood pools in the right ventricle and the right atrium, causing pressure and congestion on the vena cava and the systemic circulation. Pressure continues and is pressure on the liver and spleen, causing engorgement. And here you'll begin to see signs and symptoms of jugular vein distension and elevated CVP, anorexia because it's backing up into the GI system, nausea, abdominal pain, and dyspnea from abdominal distension. Eventually, the capillary pressure increases, forcing fluids into interstitial spaces. Here's where you begin to see edema. Tissue edema begins in the extremities and the abdomen, so you'll see pitting edema, significant weight gain, nocturia because of this capillary pressure forcing the fluids into the interstitial spaces. In terms of treatment, what we want to do here is get the person on a loop diuretic, give oxygenation to support tissue perfusion during the acute phases. We generally want them on some sort of inotropic drug. Lanoxin is generally the drug of choice to increase the strength of contractions. We may put this person on some sort of sympathomimetic drug such as dopamine or a vasodilator so that the cardiac output can be increased. Angiotensin inhibitors may be employed depending on the severity to decrease the afterload. We generally are worried about venostasis and thromboembolism with these people, so we would also employ the use of anti-embolism stockings. As pulmonary edema takes place, what's happening here is the capillary fluid is moving into the alveoli, making it harder to inhale. The lungs become stiffer because there's less pliability, there's less gas exchange in the alveoli, and you end up with an irritation in the lungs, and you may begin to get coughing with a frothy pink sputum. Know that with pulmonary edema, the hemoglobin is not completely oxygenated, so it's not just affecting the lungs in how much oxygen they can inhale, but it's decreasing the ability to oxygenate the hemoglobin significantly. We see a lot of CHF in the hospitals. Treatment is basically supportive. We may give morphine for the pain and anxiety. We may give nitroglycerin to diminish the blood return to the heart and open up the peripheral vasculature. Dobutamine and dopamine, depending on the severity, may be given to increase heart contractility and cardiac output. And of course, we would give diuretics to remove the excess volume. Oxygen is given to support tissue oxygenation and maintaining a high Fowler's position for the patient will improve respiratory capability. In this in this chapter, they talk about various types of shock, from hypovolemic, meaning a decrease in blood within the body due to hemorrhage, obstructive, which usually occurs related to cardiac tamponade or a pulmonary embolus or a pneumothorax or some major disruption in the blood flow. Cardiogenic shock, generally we see after an acute MI, and distributive or septic shock, where we see a total loss of motor tone, may be due to inflammatory mediators such as septic shock, could be due to vasodilating substances like you would see in anaphylaxis. Cardiogenic shock generally is seen, and this is where the blood fails to pump adequately, causing a decrease in blood pressure, which makes the sympathetic system respond, and that results in vasoconstriction, trying to bring the blood pressure up, and then that increases the workload on the heart and actually worsens the heart failure. So again, your body is this system trying to maintain homeostasis, and sometimes it resorts back to its pre-programmed ideas, but that's not a good thing when you actually have damage to the heart. We commonly see cardiogenic shock in acute MI patients that have 40% or greater damage to their heart muscle. The signs and symptoms that you would see would be cold and clammy skin, lowered BP, tachycardia, weak peripheral pulses, rapid and shallow respirations. If it's severe enough, you may see oliguria, which is less than 20 milliliters of urine per hour, and you will definitely see the effects of confusion because of the low oxygenation of the brain. In terms of diagnostic, we will put in central line CVP monitors to see what the cardiac output is. We monitor the ABGs to understand how bad the acidosis and hypoxia is. We may see cardiac enzymes elevated because of the damage to the muscle. Generally, we'll do some sort of an echocardiogram to show the ventricular dysfunction or the actual pumping motion of the heart to understand what the issue is. In distributive or vasodilatory shock, this is where the blood vessels dilate. There's not enough blood to fill the circulatory system. This results in less blood being returned to the heart and less blood circulated to the body. So it's basically the inability to adequately perfuse tissues. When this happens, several compensatory mechanisms take place to try and maintain homeostasis. The kidneys conserve water. You'll see a tachycardia related to the sympathetic nervous system kicking in, and you'll see diversion of blood from less to more essential body tissues. So you'll see a shutdown of the kidneys, a shutdown of the periphery, so that the heart, lungs, and brain can get as much blood flow as possible. Anaphylaxis is one of the types of distributive shock, and this is one that you will know. This is usually as a result to a systemic response to a type 1 hypersensitivity, where inflammatory mediators are released. So the inflammatory mediators would be histamine, kinines, leukotrienes, and prostaglandins that all cause vasodilation. When you get all your arterioles vasodilating throughout the body, what happens? You have a drop in your blood pressure. At the same time, the acetylcholine, kinines, and leukotrienes and prostaglandins cause bronchoconstriction. And so what happens when the bronchioles constrict? I can't breathe. So with anaphylaxis, you'll see a response where the patient has a sudden acute onset where they can't breathe, and their blood pressure will bottom out and drop out because of the circulatory issues that are going on. It is a medical emergency. This is something that you will have to be able to recognize, and with a little bit of subcutaneous epinephrine, we can reverse the effects of this inflammatory process and hypersensitivity. Sepsis is a type of shock. It is a significantly dangerous type of shock, and so we spend a lot of time and energy in today's world trying to recognize it in its beginning stages. In its beginning stages, septic shock is called Systemic Inflammatory Response Syndrome, or SIRS. SIRS occurs because of the inflammatory mediators released into the circulation, the tumor necrosis, the interleukins, the prostaglandins. All of these cause systemic signs of inflammation. So you'll see fever, increased respiration, vasodilation, warm, flushed skin. This also activates an inflammatory pathway, so you'll see some coagulation changes. Because this is so important to catch early, evidence-based practice tells us there are 4 SIRS criteria that we need to recognize when it happens all together and understand that it is the precursor to sepsis. So the criteria, namely, are tachycardia, where the heart rate is greater than 90 beats per minute, tachypnea, where the respiratory rate is greater than 20 breaths per minute, fever, where the temperature is greater than 38, or hypothermia, where the temperature is less than 36. So you could have either of those happening. And last but not least, leukocytosis, leukopenia, or bandemia, where the white blood cell count is elevated greater than 1,200 or less than 4,000, or bandemia is greater than or equal to 10%. When these inflammatory mediators are in the body, it increases the metabolic rate so that the tissues actually need more oxygen but are getting less. So this is significant to catch this early. If we don't catch it early, it goes into septic shock. And when septic shock begins, you get vasodilation, a decreased peripheral resistance, a decrease in blood pressure, and there's a 28 to 50% mortality rate with septic shock. Some other complications of septic shock are acute respiratory distress syndrome, or ARDS, acute renal failure, gastrointestinal complications such as the bowel dying. DIC can occur as a result of shock, and generally you get MODS, or multiple organ dysfunction syndrome, and we just know that the entire body shuts down. ARDS, not for testing, but just so that you know, is an acute respiratory distress syndrome. You'll see a lot of the patients in the ICUs with this disease process. This is where exudate has entered the alveoli and actually blocks gas exchange in making inhaling more difficult. Many of these patients end up on, most patients in the acute phase of ARDS are on ventilators to support breathing until this inflammatory process is finished. Acute renal failure is a byproduct of multi-system failure that occurs with sepsis. This is where there is renal vasoconstriction, which essentially cuts off urine production and results in acute renal failure. If this is allowed or not supported appropriately, the renal tubular cells will die, resulting in acute tubular necrosis, and potentially the acute renal failure can become chronic. We can kill off the kidneys. The kidneys are one of the first systems that shuts down during shock, so it's an early warning system, and we can support them well with dialysis and other interventions, but not if we don't see it soon enough. DIC, we've talked about before, where we have clotting and unclotting happening, bleeding happening at the same time. This is just one of the things that happens during shock that makes it next to impossible to save the person. And last but not least, MODS, or multiple organ dysfunction syndrome, is the most frequent cause of death in the non-coronary intensive care unit. The mortality rates vary from 30% to 100%, and we're not sure what happens. But what we do know is that SIRS leads to sepsis, leads to MODS. So this is one of the major reasons why individuals die.